practices in VTE prevention.
Well, thank you very much. It is a pleasure to be here at the standing room only symposium to talk about stroke prevention and atrial fibrillation and lessons learned from the venous thromboembolism or VTE story. I'm going to tell you how we dealt, I think, successfully with the failure to prophylax syndrome in VTE and see what strategic tips are available to apply to stroke prevention and atrial fibrillation. Because it's clear we have to change physician behavior, utilize randomized trial outcomes, apply computerized decision support, and test computerized decision support to make sure it's effective. The Surgeon General of the United States has declared that VTE is the #1 preventable cause of death among hospitalized patients. At this ESC Congress, we need to realize that venous thromboembolism is the 3rd largest cause of cardiovascular disease after myocardial infarction and stroke. And in the United States alone, VTE is responsible every year for between 100,000 and 180,000 deaths. Now, here's some strategic tips. The at-risk patients with VTE and atrial fibrillation are often not identified and they can be overlooked. And our mission is really to make sure that these patients who have previously not been prophylaxed are in the future protected with the right drug, the correct dose, and the correct duration of anticoagulation in order to prevent stroke. As for changing physician behavior, it's clear that issuing guidelines alone will not suffice. We need to have physician champions at each institution and in every group practice. The protocols have to be individualized to suit particular hospitals and cultures. We can use registries such as the DVT Free Registry, which in the US encompass more than 200 centers, and coalitions of clinicians and the public, whether that be the Coalition to Prevent DVT or the North American Thrombosis Forum, can work together to advocate for improved prophylaxis of AF patients at risk for stroke. I think that litigation is most widespread in the United States, and though it can be traumatic to a clinician and an institution, it can often, as a last resort, change practice. But a much more positive note is to engage the power of electronics and the power of computers, and to have electronic decision support and electronic alerts. And here's how this works for preventing pulmonary embolism in high-risk hospitalized medical service patients. We identified at Brigham and Women's Hospital 2,506 patients, all of whom should have been on VTE prophylaxis, but none of them were receiving it. And we randomized the clinicians of these patients either to an intervention with a single and privately delivered computerized alert versus a control group where the computer remained silent. And this was a trial of how to change physician behavior and improve implementation of prophylaxis. It was not a trial of specific types of VTE prophylaxis. Here's what the alert looked like. It told the clinician that the risk of DVT or pulmonary embolism was high, that there were no prophylaxis orders for this hospitalized patient, and it gave the physician a choice of clicking onto a DVT prophylaxis order set or reading a 40-page PDF about the evidence basis for VTE prevention, or ignoring the alert and exiting and to go on with the morning's rounds. With this single alert, we were able to increase markedly the number of medical service patients who were free from symptomatic DVT and symptomatic pulmonary embolism. In fact, using this alert system, we were able to reduce the number of symptomatic events by more than 40% over a 90-day period. What we need to do is integrate this computerized support into quality improvement initiatives and link it to an incentive system. We have to foster greater acceptance of computer guidance and couple the support with better order entry software. We have to make sure also that we use this tool judiciously, otherwise we can overpower the clinician with too many alerts and create alert fatigue. We have to make sure that the alerts come automatically and are not user-initiated. And finally, it's important to measure the effect of these alerts, to measure the outcomes of the patients, and to see whether these alerts continue to improve the provider behavior. So here's a hypothesis that an alert-based computerized decision support strategy will improve the prescription of anticoagulation for stroke prevention and atrial fibrillation, and at the same time reduce the rate of stroke and reduce the rate of systemic embolism. It might work like this. We take hospitalized patients with atrial fibrillation and we have the computer scan for any patient with a CHA2DS2-VASc score of 1 or greater. Then the computer can look to see if these patients have anticoagulation orders written. And if they don't, the patient's provider, the patient's physician, can be randomized into a group where he or she receives a privately delivered computer intervention alert or no alert whatsoever. We can then have the computer check for anticoagulation orders upon hospital discharge, and importantly, the computer can then follow up that patient a year later to determine whether a stroke has occurred and whether the patient remains alive. So, in conclusion, we must catalyze the clinical implementation of stroke prevention and atrial fibrillation guidelines. We've witnessed a decade of stagnation. 10 years ago, the Euro Heart Survey showed that 40% of high-risk AF patients were not being prophylaxed, and our GARFIELD data come up with the same number. 40% of patients who by guidelines should be prophylaxed with atrial fibrillation are not receiving anticoagulation. And we've learned from the VTE prevention story that a multifaceted approach is best. Computerized decision support has a proven track record and is an especially promising strategy. Thank you very much.
Well, Sam, thank you very much indeed. I think the time has now come to take some questions from the audience. Are there any questions? If you have them, please come up to the microphones. And if not, complete your question cards. Since it's very difficult to see from up here, are there any specific questions from the audience? Yes, microphone 1.
Franco Piovella from Italy. To Professor Gotto, I've seen in your table that the rate of mortality was 23% if they fail in the first 4 months to continue anticoagulation. But the sum of stroke and bleedings is 8%. So what happened to the other 12 or so?
Well, microphone doesn't work.
Okay, it's on now.
Is that okay?
Yeah.
Yeah, it's a very good point. I mean that, that is a kind of observation. If, patient, we have to stop warfarin within 4 months, the rate of death is more than 20% within a year. It means probably some of the patients, for example, lung cancer, should bleed. So that kind of patient, should continue warfarin. That's probably the reason. We didn't look into the detail, but your point is very important.
Thank you.
Okay, any further questions? If not, I'm going to hand over to Professor Hacker, who's now going to take us through 2 cases, an interactive discussion here. At any time, of course, if you do have questions, please either hold up a card or come to the microphone.
Okay, good afternoon. And my presentation is under the heading Beyond Guidelines. I'm not talking about guideline-based interventions here. Escape. Where is it? Okay.